All right, this presentation is the second part of our head injury mechanisms and assessment. And now we want to talk about TBIs, or traumatic brain injuries. The mechanism is typically indirect. The most common thing that happens is an acceleration and then a contracoup mechanism. So the brain and the skull are accelerating. The skull stops, such as the head hitting something, and then the brain shakes around in the skull, causing a contracoup injury. Okay. Again, this can be traumatic, it can, as far as being acute, or it can happen from repetitive stress. Okay, so the etiology here, or how it happens, it's thought that what happens with our traumatic brain injury, which is another name for concussion, is that there is axonal damage inside the brain. So you can see here that our axons can be stretched or twisted or compressed, okay? And then they just don't function correctly. So at this very microscopic level, our axons that make up our cerebrum are damaged, okay? And what actually then happens that makes the brain sort of behave weird, if you will, is that there's an alteration in brain metabolism. So we think that what happens is, as a result of this axonal damage, there's this increased glucose demand that puts the brain in a very vulnerable state. So then, if the patient doesn't allow this injury to heal, if the axons aren't allowed to repair themselves, then the patient may be at risk for second impact syndrome, and the brain is thought to be in that vulnerable state because of this alteration in brain metabolism. Okay. All right, so what happens then is the brain is experiencing impaired function, and there can be a varying time frame for that, and that means two things. First of all, many signs and symptoms will onset immediately when a patient has a concussion, but we should also expect that the function of the brain may change. The patient may report various deficits or signs and symptoms as the time continues post-injury. And also there can be extreme variance in severity. So there are grading systems. In fact, in the NATA position statement, there are two different grading scales that we could use for concussion: mild, moderate, and severe, grade 1, grade 2, grade 3. But each person's concussion we're going to treat as an individual, not comparing it to anyone else, and knowing that some folks could simply have a headache and it could be gone in 7 days, and another person could deal with the post-concussion symptoms that last even years, multiple years. So it's going to vary, and each one is different for each individual. There are also 3 categories of signs and symptoms. So the patient may report to you physical symptoms, mental symptoms, or emotional symptoms, and we need to be sure that we monitor those as well. Okay. All right, I'll go over those in greater detail in a little while. Okay, so, in our physical symptoms, they could say they have a headache or nausea. Our cognitive symptoms, they may feel confused or have difficulty concentrating. And then our emotional symptoms, we need to ask them about things like sadness or irritability. Okay. In an initial assessment, we wouldn't ask this, but as we go into our reassessment of concussion, we want to ask about sleeping too much or sleeping too little. And if they're feeling particularly drowsy, which drowsy could be something, sleepiness could be something that onsets initially in our initial assessment. Okay, so we break our symptoms down into physical, cognitive, and emotional, and then over the long haul, we want to ask our patients about their sleep, because it's been demonstrated in a lot of concussions that sleep can be disrupted by concussion. All right, next up, post-concussion syndrome. So signs and symptoms of a traumatic brain injury lasting longer than expected. And again, I'm using TBI and concussion interchangeably. They mean pretty much the same thing. This post-concussion syndrome, if you read in the latest Berlin statement about concussion, that consensus statement, they're basically saying 10 to 14 days is when most concussions should resolve. So if you have a volleyball player that sustained a concussion in practice, and it's 3 weeks later and she's still having headaches when she tries to take tests at school or when she stares at computer screens for too long, and sometimes gets headaches in the middle of games, then that can be described as post-concussion syndrome. All right, so we're still looking possibly, as far as the etiology, at altered neurotransmitter function, so the axons haven't healed all the way. And again, this post-concussion syndrome is characterized by interference with ADLs, such as concentration and attention span. So cognitive rest may be indicated for post-concussion syndrome, Also, what you should know as a practitioner is that if you have a patient that is having concussion symptoms at 14 days and beyond, this is something that has to be referred to an appropriately trained person, such as a neuropsychologist, for further follow-up and for what is considered a sort of multidimensional kind of care. Do they need a specific form of physical therapy? Do they need neurocognitive testing? Do they need, medication for particular aspects of post-concussion syndrome if they're experiencing depression or anxiety that has onset because of it? So this is no longer a situation that the athletic trainer can manage themselves. Because essentially what we do with concussion is we restrict the patient's participation in school and physical activity until the brain recovers, which it usually does spontaneously without anyone having to do anything, just allowing it to rest, and then life goes on. But this patient is going to be much more complex to manage, and there's no way the athletic trainer should do it on their own. Okay. Second impact syndrome is the biggest thing that we worry about with our concussion patients, as in maybe they're not going to tell you that they have a concussion because they want to play, and they go back into the game. This almost always is a fatal condition that occurs in the young developing brain. I mean, there have been instances of it in college, but also we worry about it more at the high school level. So it's a trauma that's sustained after there's an initial concussion. Possibly the brain is very vulnerable again due to that metabolism issue, or also consider that there may be altered blood flow. So what happens with this trauma in a concussed patient is that they then have a quick onset of increased intracranial pressure. The brain begins to swell, there's rapid bleeding, and then there's rapid deterioration. So we talked about this in class the other day, but this is somebody who's laying on the field. You're going out to get them, noticing that they are unconscious, that their vital signs are altered, that they are quickly, that you may do your cranial nerve assessment and notice that the pupils are either constricted or dilated. It's typically dilated, or that they are unequal. So a positive Pearl assessment and all sorts of bad news. So this is, again, a life-threatening situation. Another thing I wanted to point out to you when we're doing our assessment is we've talked a little bit about upper motor neuron lesions. So this seemed like a good time to remind you that when you're doing an assessment of a brain or cervical spine injury, which when you have a brain injury, a head injury, you're still going to do a little bit of a screening of the cervical spine, that we need to be able to differentiate between upper motor neuron and lower motor neuron lesions. So that upper motor neuron lesion was the thing we were looking for when we did the Babinski's and the Oppenheim's test. And the patient would display weakness, increased reflexes, and increased muscle tone, but not atrophy. And then with a lower motor neuron lesion, which you now know is a peripheral nerve problem, the patient will have weakness, atrophy, decreased muscle tone, and decreased reflexes. Okay, so the peripheral nerves go from the spinal cord to the periphery, say the fingers or the toes, and the upper motor neurons go from whatever spinal level we're discussing, so let's just call it C6, up to the brain. Okay, so when a patient has an injury to an upper motor neuron, they're going to have increased reflexes and increased tone, and that we would correlate with perhaps the decerebrate decorticate posture, also with a positive Babinski sign or positive Oppenheim's test. Okay, so that's a little, I wanted to throw that in there just because we didn't cover that thoroughly enough when we were doing our acute assessment of on-the-field patients with perhaps cervical spine injury. Okay, all right, so this assessment is just what is in the Starkey textbook. This is right from chapter 20, okay? And then in the next presentation, I'm going to go over more current concepts of assessment. So of course, with your head and C-spine injuries, you need to be able to recognize the injury, determine if the athlete requires additional testing, more advanced medical attention, and then make a sound return to play decision based on as much information as possible. So with your return to play decision, we're going to discuss that in subsequent lectures. That's a really important aspect of concussion management. Okay. All right. So again, we've done a lot of this. We have our initial or on-site assessment, and then we will move into a sideline assessment. So I'm not going to read this to you. I'm just telling you, I know these are things that we have already been over. Just a little bit of reminder here. Okay. And our decisions to be made, this is what I referred to as disposition. Are you taking them to the sideline? Do they need medical care this evening, tomorrow? Do we need to just watch them for a while? So, this has to do with, again, the disposition of the patient once you do either your on the field or sideline injury. Okay. All right. So our history, again, focusing mostly on a head injury. Did the patient lose consciousness Where are the symptoms? Describe the MOI so we can understand more about the force, because we can now correlate the force with the injury that we think for the injury that we would put in our differential diagnosis. Has there been a previous injury, especially the previous history of concussion? How many have you had? And how much time has gone by since you had your last one? Has the patient experienced any weakness or any persistent symptoms? Okay. When you do your inspection, you're looking at the position of the head and the C-spine, of course, visually inspecting for battle sign and raccoon eyes. Again, this is coming right from that examination chart in chapter 20. Looking at the eyes to see if they are focused, to see if they're equal, nose and ears, skin color, and looking at evaluating that patient's emotional control, just seeing if they're having some issues with irritability, acting irrationally, crying, etc. Because that would give you a hint, too, that they're having a head injury. All right, for your palpation, when you suspect a head injury, you're for sure going to palpate on the cervical spine to rule out any abnormalities there and rule out a fracture. That has to be done for every head injury that you do because you don't want to miss a catastrophic injury or a serious injury. For your scalp, or for skull injuries rather, you're going to palpate for laceration, swelling, deformity, and crepitus associated with either a laceration or a fracture. And then you would want to go ahead and palpate also the throat and the musculature around the neck to make sure that there's not any spasm or any issues with that. Functional testing. So now we're talking about how are we going to assess our patient for concussion? How are we going to actually assess the brain? So we need to assess the brain's cognition, the balance, and the patient's symptoms. We're going to go into a lot more detail about this. So multimodal testing is prudent, which means we need to test all of these things. And perhaps we're going to use a variety of assessments. That's another way to interpret the word multimodal. No one test can be used to diagnose, and our standardized tests are superior to non-standardized tests, and I will describe that as well. Okay. Also, in our functional assessment aspect, functional assessment is sometimes synonymous with special tests. We want to assess our vital signs, specifically pulse, respiration. We can measure pulse pressure and blood pressure. I will describe pulse pressure to you in class. And we want to perform serial assessment to monitor for deterioration. All right, and last but not least, in our functional assessment, which, as I said, is synonymous with our special tests, we want to be sure to evaluate neurological function using Babinski's and Oppenheim's, especially on unresponsive patients, and then cranial nerve assessment, as well as spinal nerve root evaluation. Spinal nerve root evaluation is your dermatomes and myotomes, and so we'll be working on those during this head injury unit as well, in order to rule out a cervical spine injury. All right, next up, current concepts in concussion assessment.